He served as the New York City Health Commissioner 2002 to 2009, where he also was, with the backing of Mayor Bloomberg, was a really transformer across multiple public health fronts. Before that, served in India in TB control, and then a stint for 92 to 96 in New York City after the outbreak there. So please join me in welcoming Dr. Tom Frieden. He's going to do a presentation for us, and then we'll have a conversation after that. Thank you so much, Tom.
Thanks very much, Steve, and thanks to CSIS for bringing us together. I know we've got people here who've had a long history of working in polio eradication. I see my old friend John Andrews here. We were together in India where John was working on polio eradication there. And we're at a remarkable time. The world is closer than we've ever been to eradication, and we really do have the opportunity of getting over the finish line in the next year. That doesn't mean it's inevitable. In fact, progress is never inevitable. And I'd like to take us through just a few slides to look at where things are at, and then Steve and I will have a conversation, and maybe we'll have some chance for a discussion with folks in the room. The bottom line is that we are closer than ever, and some of the critical things that have gotten us to this point are the use of emergency operations centers. This enables a structured, focused, accountable, coordinated approach within country. Strengthening of routine immunization, which has been critical to boost the immunity throughout the country. Environmental surveillance, which keeps us all honest. And I'll show you some very concerning environmental surveillance data later. But we've expanded this, and through the CDC laboratory and laboratories in our network around the world with WHO, we've been able to track what's happening even if surveillance in humans is imperfect. If you look at every successful public health program, they all have at least the key characteristic of an information system that allows accountability. And environmental surveillance is one aspect of that for polio. Innovative vaccine strategies, whether it's vaccinating kids at transit posts or nighttime vaccination or vaccinating using a variety of community engagement or community leaders, all of that is crucial. Community engagement has been absolutely essential to every aspect of progress, and there is no alternative to an engaged community. The use of IPV, which I'll speak about a little bit later, all of these have been key interventions, but right now it's all about Pakistan and Afghanistan, and I'll talk about the details there in a bit. Africa may well be polio-free, but we're not out of the woods yet. We don't know that for sure. There are parts of Africa where surveillance is suboptimal, and we know that in Cameroon, polio spread for 2.5 years before it was recognized. So we are optimistic. We're confident in the quality of surveillance in Nigeria. I was just there a couple of months ago. I was very impressed by what they're doing. They've got an AFP rate of 17.9. They have very few gaps in surveillance. So I think we have a reasonably high degree of confidence that if polio is out of Nigeria, though we won't be certain for the 3 years, and there are still some relatively inaccessible areas, but there are other parts of Africa where it's possible there could be clusters continuing to spread. Doesn't mean that we haven't made huge progress, but it does mean we have to continue to expand surveillance. Rigorous implementation and continuous innovation will both continue to be essential. That's really the key. For any public health program, you need political commitment and technical excellence. And that technical excellence includes rigorous implementation. That means accountability, that means data, that means going to the front lines, that means not fooling yourself about what vaccination rates are compared to what you wish they are, and continuous innovation. And one of the biggest lessons from the review of the smallpox eradication program is how much ferment, how much continuous innovation there was at every stage of the effort. We may look back with 20/20 hindsight and say, oh, they knew what to do, they did it, it got done. But if you read something like Bill Foegele's book, House on Fire, you really get a sense that they were continuously looking at who to vaccinate, how to vaccinate, where to vaccinate, how to track, who to work with. All of those things are essential, as is political leadership, as is technical excellence. Well, just to remind us that in 1988, there were 125 countries with polio. There were nearly 1,000 kids getting paralyzed by polio on an average day. Polio cases have fallen by more than 99.99%, but that's not enough. 4 out of the 6 regions are polio-free, but that's not enough. Type 2 polio has been eradicated, but that's not enough. Nigeria is no longer endemic, and the African region has not had a wild polio case in more than a year. And in this time, 13 million cases of paralytic polio and 650,000 deaths from polio have been averted. So far in 2015, there have been 41 cases, and what you can see is really a trajectory of what's happened. There was rapid progress through the 80s and 90s. The 2000s were a time of stagnation. Progress in India stalled. Nigeria went backwards with rumors about the vaccine. Spread in Nigeria, then spread to 11 or 12 countries all over the world. And it looked like we were not going to be able to get over the finish line. I'll be perfectly open with you that in 2009, when I became CDC director, I was not certain that polio was eradicable. I had been in India. I had seen the challenges there. And we had a public health grand rounds at CDC. Hamid was there and others. And we reviewed the data in detail from India. There were kids getting polio after 10, 12, 15 vaccinations. And it just looked like something wasn't going to work. It just wasn't going to happen. But then it did. India became polio-free, and it did that with enormous political commitment and will at all levels. The true heroism of more than 2.3 million vaccinators to reach local communities, hundreds of millions, in fact, over 1 billion doses of vaccine given, very specific tactics to reach children in underserved communities, very importantly, making clear to the community that we don't just care about polio, we care about the community, and a block development program was important to get started. Targeting to make sure that no children were missed, and innovations that have not only gotten rid of polio from India, but are in use today to strengthen public health generally and immunization services specifically. So the legacy for India to have gotten rid of polio was first that India itself is healthier. India has a better vaccination program, it has better public health programs, it has confidence in what it can do. And for the world, it breathed hope into the world of polio eradication. And I'll say that when I first moved to India in October of 1996, John Andrews was my neighbor, and there was a lot of resentment of the polio program because workers from many other programs were being pulled to work on the vaccine campaigns. They had more money than other programs. But I felt very differently because I saw that the progress that India had made at that time gave tremendous confidence to society that you could achieve great things, that great things were possible in health, and that even a public-private partnership led by the government could achieve great things. And that made our work in tuberculosis control in India much more possible. And they taught many lessons for what worked and didn't to get the implementation done. Well, with India off the map, the next stage was to look at Nigeria. And there, many partners worked intensively. The Gates Foundation supported the emergency operations centers. At CDC, we began a program on the National Stop Transmission of Polio programs, NSTOP, where we sent ultimately over 250 Nigerian staff who we intensively trained, mentored, monitored, and supervised to more than 100 of the high-risk local government areas. We met with them every 4 to 6 weeks, and we systematically improved the performance of every aspect of the immunization program, seeing in Nigeria dramatic improvements in routine immunization rates in only 9 months. Overall, there was a huge focus in Kano. Bill Gates, Dangote, and others worked with the governor and got accountability into the system. In Borno and Yobe, there were very gifted and talented regional and provincial leaders who we were able to support. And some of the key success strategies were those emergency operations centers. It's nothing magical. It can be simple, but it has to be accountable, getting everyone in the same room, on the same page, working together. Encouraging key religious leaders and polio survivors and journalists to become advocates, working through barriers one by one to reach every child, including in security-compromised areas. Health camps, which I was pleased to visit on several occasions, and see how the tremendous health needs of the community could be begun to be addressed through health camps, and expressed to communities that we don't just care about a virus, we care about you as human beings, and we're going to do what we can to strengthen the systems there. Combined IPV-OPV campaigns to boost immunity in hard-to-reach areas. I'll talk about this more later, but I have to say IPV is both a success story and a cautionary tale. We have known for almost 25 years that IPV would provide an additional synergistic boost to vaccine programs. In fact, the study done to demonstrate this was done coincidentally when a polio outbreak occurred, and demonstrated unequivocally that there would be a boosting of immunity. But there was a dogma that if you introduced IPV, it would undermine OPV. That if you introduced IPV, people would abandon OPV and not have confidence in it. That there would be problems with the introduction. In fact, in Borno and Yobe, northeastern Nigeria, IPV was introduced just before Boko Haram really became very dominant in that area. And if it hadn't been introduced then, it is quite possible that we would not be celebrating a year of polio-free Nigeria now. And there was also a hard-nosed focus on underperforming and vulnerable areas. And actually, Nigeria learned from Pakistan, which in 2010 and 11 had started a very accountable dashboard before every vaccine for every provincial and sub-provincial area, and they said quite simply, if you're not ready, we're not sending you vaccine. And that was enough pressure to get real improvement for those years in Pakistan. Of the 41 wild polio cases in 2015, all have been in Pakistan and Afghanistan. And I've just narrated the past few years, but you can see it on this slide. You see in dark blue Nigeria, accounting for many of the cases through the 2000s, and then none this year, and very few in the last year. You see Pakistan and Afghanistan now causing all of the cases, and India having gotten over the finish line in 2010, early 2011. These are the numbers behind that slide. So you can see the numbers are getting less and less. We're making more and more progress, but we should not be overconfident, because this is where we've seen polio cases just in this year in Pakistan and Afghanistan. I don't think I have a pointer here, do I, or a mouse? No. All right, well, imagine there are two corridors, one going in the lower half of that, the second the upper half of that, and there's a lot of transit between Pakistan and Afghanistan. And remember, for every single clinical case of polio, there may well be 1,000 subclinical cases. So 41 sounds great, but 4,100 doesn't sound so great. We've still got a long way to go in these countries. In Afghanistan, we've seen essentially stagnation over recent years, which is unfortunate because for polio and other programs, we've seen real progress in the past. There are significant problems of security. Just last week, another group of workers was injured and killed in Afghanistan by a roadside bomb. So we know the challenges are substantial, but we also know that with good management, they've been able to do better in the past, and they can do better here. One thing we have going for us is the sparse population density in Afghanistan. That is relatively inhospitable environment for the virus. But without better management, we're not going to get over the finish line, and that's the goal. What you see in the map here are the transit points, and per month, the number of children going across the border is around 100,000. It's a huge number, large population movements, but that's also an opportunity for more transit point vaccination. When I was in Pakistan a couple of months ago, they shared with me that one of their concerns is that if you do a transit point vaccination, as you do that, there's a line. There's a group of people, and there's a risk that someone will throw a grenade and kill people there. So it really emphasizes how challenging the security environment is in the area. But by focusing on a national emergency action plan, which is now finalized in Afghanistan, establishing emergency operations centers, which are now being established for the first time in Afghanistan, improving the quality of campaigns, finding those persistently missed children. I see Sir Liam here and really thank Sir Liam and the IMB for their excellent reports. I have to say that as reports go, they're as clearly written as any report I've seen in my career. And more importantly, they've focused on the key issues, such as finding those persistently missed kids. What we learned from Latin America when they got over the finish line with polio was you could have all the campaigns you want, but if you're vaccinating the same people over and over again, it's not going to help. Access and security, cross-border, cold chain has been a problem in Afghanistan that has to be addressed, and strengthening of routine immunization. Now in Pakistan, we have seen access dramatically improve. So the number of kids who can't get reached has fallen dramatically. And if you look at the WPV-1 cases, they're at a low, but it is the low season. So we'll see what the next few months hold. The next slide, frankly, is the most concerning one that I'll show. And this is a little hard to read and follow. This is environmental surveillance in Pakistan. The key thing to note here is that there's a lot of red on this chart, and there's particularly a lot of red in August, so within the last month or two. What this tells us is that there is poliovirus surviving in many parts of Pakistan, and the country really is at risk of not being able to get over the finish line in next year. They do have a focused plan to stop the transmission in all of the reservoirs, to increase population immunity, and to sustain interruption through the routine immunization and polio eradication strategy. They have really changed their paradigm from how many did we reach to how many did we miss. The definition of an epidemiologist in my book is someone who loses sleep over denominators. And in Pakistan, they're losing sleep over denominators. They're thinking about those kids who they're not reaching. Now, they're not sure of the numbers, but it's a good change from focusing on, look, we reached this many, to, ooh, we didn't reach this many. And that number is decreasing with time. They have a more rational schedule of subnational immunization programs, focus on quality. They've had problems paying their frontline vaccinators. This is such a problem. This was a huge problem in Nigeria toward the end. In West Africa, this has been one of our major problems with Ebola, that the people on the front line don't get the care, the attention, the support, the supervision, the payment that they need. We have to do better supporting the front lines in health and public health. Also, they've focused on health camps, again, very important, access issues, IPV, IPV very well accepted. This is really an important point, but has a lot of potential, and strengthening of surveillance and transit vaccination. Now, this is just some actual data from Pakistan, and it shows that there's uneven progress among and within districts, but what I'd like you to focus on here is FATA right in the middle. And although they're not where they need to be, they haven't reached that goal line, they've come up dramatically. And for the first time in many years, house-to-house vaccination was done just this past month in FATA. So with improving security, we're seeing improving program, and with improving management, we're seeing improving quality. More than 20 years after the data clearly showed that it could be an important boost to eradication efforts, IPV is finally being used in this mode. It may well have been critical to the success in Borno and Yobe in northeastern Nigeria. As Hamid said at our Polio Oversight Board meeting on Friday in New York, IPV is not going to work where vaccination levels are low. It is not a way of addressing a poorly functioning vaccine program, but especially where you have limited access to populations, and especially where you have a lot of other enteric infections, which we know interfere with the efficacy of the oral polio vaccine. It can be a very important tool. What have we seen? Everywhere it's been used, 90+% acceptance, widespread welcoming of IPV. I'm in the mode of quoting Yogi Berra these days, mourning still for his passing at age 90 last week, but Yogi said, in theory, theory and practice are the same. In practice, they're different. We can't just assume what's going to happen. We have to try it and see. And when we tried OPV in Kenya, where CDC did a pilot study, there were no problems. It was easy to use, well accepted, didn't undermine OPV. There is now a critical supply shortage of tens of millions of doses, but it may still have an important role in Pakistan and Afghanistan. I want to talk in concluding about the future and about some of the legacy. There's probably nothing that can emphasize the value of this legacy as eloquently as Nigeria getting over the finish line in Ebola control. Let me tell you that since CDC activated our Emergency Operations Center on July 7th of last year, it has been largely all Ebola all the time for us at CDC, and although it is off the headlines now, we have never left the front lines. We still have at CDC more than 150 of our top disease detectives, doctors, nurses, scientists in the front lines in West Africa. We've had more than 60,000 work days there. We've been in every community where Ebola has spread. We've done more than 25,000 PCR tests for Ebola there, with about a third of them positive at the height of the outbreak. We've helped to coordinate and oversee every aspect of the response. But the moment that was most frightening for me was when Ebola hit Lagos. Lagos has a population roughly equivalent to all 3 West African countries combined. And unlike West Africa, which is off the beaten path to a great extent, Lagos is at the center. If Ebola had gotten out of control in Lagos, the world would be a dramatically different place today. It would be all over Lagos, all over Nigeria, all over Africa. It would change health care, not just in Africa, but globally. It's very hard to express how difficult it is to manage health care when there's Ebola. Because even if you only have one case in a community, you may have 1,000, 10,000, or as in Guinea, we estimate about 1 million fevers per month for every one case of Ebola. So that means you're going to have to, in theory, treat everyone as if they might have Ebola, but that's not possible. So the only option is to get rid of Ebola. And what they were able to do in Lagos was rapidly to mobilize. And we at CDC sent 10 of our top disease detection people there within a couple of days. We immediately redeployed 40 and ultimately 80 of the NSTOP staff, those staff that had helped improve vaccination programs. We told them, stop working on polio for a bit, sorry. Your focus now has to be Ebola. They were able to identify 894 contacts. They did 19,000 home visits to check for symptoms and to measure temperatures. They identified 43 suspects, 19 secondary cases. They constructed an Ebola treatment unit in 14 days. Let me tell you, those were the 14 longest days of my life. That was way too long, and yet it was very quick. It was way too long because when they didn't have it, one person went to a second city, Port Harcourt, and started a second cluster. They then repeated that entire operation. I think you've heard earlier, we'll hear more about the EOC in Nigeria, but it was the Nigerian deputy incident manager who came to be the incident manager for the Ebola response. That was crucial. They then relocated to Port Harcourt, repeated that same whole undertaking, established an EOC, did the contact tracing, and in 3 generations of spread, they stopped the outbreak. And the world is a dramatically different place because of that, and it would not have happened without the polio infrastructure. There are continued challenges in Nigeria with inaccessibility, CVDPVs, organizational, but I was just there a month or so ago, and I was quite impressed by the high level of functioning of the EOC, by the good quality of surveillance. Now the challenge for Nigeria, they've got new political leadership. They've got these 2 successes under their belt with Ebola and polio. Now their challenge is to really do what they need to do to address their leading health challenges of malaria, HIV, reproductive health, immunization, strengthening. They have become, as used to be described for Asia, they've become the sick man of Africa. And Ebola and polio have shown that that doesn't have to be. Smallpox elimination, which I mentioned before, is worth remembering. Again, we look back, and yes, there was a lot of advantages with smallpox compared to polio, but the amount of effort in India alone, there were approximately 1.3 million visits made during weeks for month after month, and they continued at the rate of 300,000, 400,000 per month for the next 2 years, 4 million visits to households to look for smallpox cases. In fact, 100 million houses were being visited per week during this time. It was the largest public health program ever implemented. So it wasn't easy, but it was possible, and it was successful. Eradicating polio will be one of the greatest achievements in human history. We will continue to focus on getting over the finish line in Pakistan and Afghanistan and stopping all of the circulating vaccine-derived polio outbreaks and cases, ensuring that we have strong surveillance so we don't have any unpleasant surprises, as we did in Cameroon with 1 case after a couple of years, ensuring high vaccination coverage so that if there is importation, we don't have reintroduction and return of endemicity in new countries, and applying the polio gains more broadly so that this wonderful collaboration of public and private sectors, of the healthcare system and civil society, this visibility of public health to the political leadership at the national, provincial, and sub-provincial levels is something that not only serves to eliminate and eradicate polio forever, but also leaves a legacy of stronger health and public health systems in countries throughout the world. Thank you very much.
Remaining. Thank you, Tom, for that presentation, and thank you and congratulations, your role as chair of the Polio Oversight Board and all of the leadership that you've shown. Your presentation was a pretty fine mix of enthusiasm, optimism, and a sort of sobering reminder of the complexity of this endgame that we face, and that this is a complicated and sometimes elusive enterprise that is underway globally, and some of what we've seen is remarkably impressive, and some of it is really caution for us to proceed very carefully in making sure that we know exactly what the situation that we face is. Now, the Polio Oversight Board did meet on Friday. We understand there's a request to expand certain dimensions, surveillance, to expand the focus upon risks of outbreaks and the ability to respond rapidly in the event there are new outbreaks in these endemic countries, but also in other places that are unstable where there's been a dissolved health system or political order. A bigger focus on getting to those children that are being missed and a stronger approach on containment. And a number of other items, but those items we've heard a little bit about. We've also heard that there's an ask now for an additional $1.5 billion. So this is a significant moment of adjustment that we're in right now. And it's one that is going to place higher demands on all of us as government partners, as non-government partners, as national governments and others. Maybe you could unpack this a little bit. It would be useful to hear your advice as chair around how to make the case to a public whose support we require, but who may not fully understand the complexities and dimensions, in saying that this effort needs to be refined and adjusted and intensified and deepened, and it's not without cost. It requires some temporal adjustments to add an additional year into the mix. Maybe you could talk a bit about that, because I think the task now is really a communications and strategy task that's in front of you and the other major partners.
To summarize it in one sentence, polio eradication is hard, but it's worth it. It's hard. It's going to cost more money. The challenge in Pakistan and Afghanistan has to do with both management and security. And there are always unpleasant surprises, like the difficulties the vaccine manufacturers are having producing enough IPV. But it's worth it, because, and another issue that I think isn't sufficiently recognized is how hard biocontainment is going to be. This is a stepwise process where early next year, the world is supposed to, in one wonderful synchronized week, switch from using trivalent vaccine with the 1, 2, 3 types of polio for oral vaccine to bivalent vaccine, types 1 and 3. That's important because the bivalent vaccine is a little more effective than the trivalent vaccine against those types, and it eliminates the risk of vaccine-derived type 2 polio outbreaks. But we're seeing circulating vaccine-derived polio outbreaks, so that's making people nervous. The SAGE group of WHO needs to make a determination next month to affirm that we're going to go through that switch, despite the lack of IPV in the quantities that we had wished. But that will be safer for kids, and then once we're over the finish line, we'll eliminate OPV entirely, and we have enough IPV to use. So we're seeing, on the one hand, it's hard. It's taken much longer than any of us would have wished, much more money. And there will be a financial gap. The real risk isn't the next year. The real risk is if we don't get over the finish line in 16. Then the costs really begin to escalate, because the gap of approximately $1.5 billion is big. But for every year that Pakistan and Afghanistan don't go over the finish line, don't get over the finish line, it grows by $800 million. It's worth it, polio eradication, because on the one hand, it will allow us to repurpose a lot of these resources to vaccination and other public health programs. It's worth it because we'll be able to reduce the risk of vaccine-associated polio, which is 1 in a million, but not 0, for the countries using OPV. It's worth it because it will give confidence around the world, and we're training hundreds of thousands of people how to do better public health programs. Ultimately, it's worth it because it's the ultimate in both sustainability and equity. It's forever and for everybody.
What is it going to take to cover that $1.5 billion additional gap, in your mind?
Well, we've got the Gates Foundation in charge of the Finance and Accountability Committee, and Gates, along with WHO, have been very effective at mobilizing resources. For many countries, it will really involve just continuing the budget as it was before. So it's not necessarily going to be a huge new budgetary ask, but the details of that still have not been worked through. What the Oversight Board was asked to vote on Friday was which scenario we think is most likely. And the scenario we chose as most likely was that we could get over the finish line in 2016 in Pakistan and Afghanistan. That's not a foregone conclusion. It's going to take an enormous amount of hard work, creativity, and courage.
I'd like to take advantage, if we have a microphone, I'd like to take advantage to ask Sir Liam Donaldson and Mohammed Pate to just offer a quick comment or question, since we have the two of you here. There was quite a bit of discussion in Tom's presentation around your contributions and perspectives. Liam, if I can put you on the spot, just there's a microphone right there. I'd appreciate that, and then we'll ask Mohammed, if you don't mind, and then we'll come back for Tom to close.
Thank you very much, and it was a very, very clear, beautiful strategic analysis.
Liam, I don't think that's on. I think that needs to be switched on.
It was a very beautiful, clear strategic analysis, so thank you very much, Tom, for that. I think my concern really is your very strong epidemiological point that even if we had one case remaining, there'd still potentially be 1,000 people capable of transmitting polio. And smallpox was different because in some ways it was different as a disease. You could see it and so on. And I just wonder now how we're going to continue to get what you, I think, very rightly described, a balance between, first of all, standardizing all the programs on best practice, but secondly, creating even more innovation, because it seems to me that it won't be enough to standardize on best practice. We're going to need some further leaps forward, transformations, if we're going to get there, and I just wonder what those transformations might be.
Thank you. If you can hold for a moment and we could get some thoughts from Mohammed Pate.
Thank you, Tom. I think it was an excellent talk. I think, given where we are in the polio eradication effort, the technical and financial aspects are, in a way, the bit of the easy bit of it. The political angle, I think it's equally important, or not even not more important, in terms of mobilizing these additional resources, but also sustaining some of this gain so that we don't see reversals. At least at the country level, that was a key part of what explained, I think, what Nigeria has been able to do. I wonder what's the thinking at the POB in terms of the political angle to sustain, mobilize, and get us to the finish line.
Thank you.
Starting with innovation, I believe that what's most effective is innovation large and small. There are lots of areas for micro-innovation, as it were. Things that in a local area might be decided with which are the village leaders who are best to reach. Does nighttime vaccination work? How can you vaccinate most safely? Can we expand environmental surveillance sites, which is being done to more places? That's one of the reasons we're finding more virus. I think, though, more broadly, the most effective programs really do base decisions on data, and they base how they operate on what they see. That's why, for example, the use of IPV in high-risk areas is so important, where you may not be able to get in 5 or 10 times to vaccinate kids, then maybe 3 times with an IPV will be enough. To figure out how to optimize that mix. Now we've got a very difficult problem of not enough vaccine supply in IPV, and a little bit of a push-pull for where it should best be used. Figuring out, based on modeling, for example, in a larger analytic framework, where are you most likely to interrupt transmission by using this scarce resource of IPV? I don't think we're going to see real breakthrough, big innovations with new vaccine technologies in the next year, but we are seeing some advances in laboratory techniques, for example, that might give us a point-of-care diagnosis of the environmental sample that would speed things up. A lot of times the innovation is to work time out of cycle. So instead of 2 weeks, it takes 1 week, or instead of 1 week, it takes 2 days. And that kind of rapid detection, rapid response is the core of what we're advocating in the global health security agenda as well. this real focus on what's the actual situation and what's the most effective way to address it. In terms of political commitment and financing, two tightly connected issues, I think you're absolutely correct. This is essential. I was very encouraged to hear from Senator Aisha, the polio focal point in Pakistan, that the Prime Minister had called all of the chief ministers together, I may not remember all four now, and had said there were 4 priorities for his administration: polio, safety, I think, and 2 others.
Road safety.
Actually, security and I think environment and education, if I remember correctly, but don't quote me on that. But one of the 4 was polio. That was the point that was important for us to hear. And I think it's possible, and I'd be interested in your thoughts, Mohammed, about that with Nigeria having begun to commit more resources from the federal level for polio, and Pakistan now doing the same, there's a real sense of skin in the game. There's a real sense that this is not something that the world is imposing on us. This is something that we're doing, we're committed to as a country. You certainly saw that in India, which has spent an enormous amount of its own money on polio eradication. And this idea that it's really owned by the country, a priority of the country, is irreplaceable, because only from within the country can you identify what those areas for innovation and acceleration are. So we're very encouraged to see the progress, but we're not out of the woods yet.
Thank you, Tom. Please join me in thanking Dr. Frieden for being with us this morning. Thank you.